Hello friends, my name is Ankit. I make educational videos on US healthcare. I also write blogs on the latest US healthcare trends. I'll provide the link in the description below for your reference. If you are new to my channel, welcome. Please like and subscribe to my channel so that you have update on the latest content. In the previous video, we talked about the challenges with the current prior authorization system. There has been a discussion around various new upcoming standards, which includes electronic prior authorization. In this video, we'll talk about the electronic prior authorization Da Vinci architecture, as well as we'll talk about some of the components related to implementing the electronic prior authorization process. What is Da Vinci burden reduction track? So this implementation guide is part of a set of interrelated implementation guides that are focused on reducing clinician and payer burden. The Da Vinci burden reduction implementation guides are coverage requirement discovery, documentation template and rules, prior authorization support. So we'll now dig deep into each of these IGs. Coverage requirement discovery, also known as CRD, it provides decision support to providers at the time they are ordering diagnosis, specifying treatment, making referrals, scheduling appointment, etc. Documentation template and rules, also known as DTR, it allows providers to download smart questionnaire rules, for example, SQL, and provides a Smart on FHIR app or EHR app that executes them to gather information relevant to a performed or planned service. Execution of the questionnaire and rules may also be performed by an application that is part of the provider's EHR. Prior authorization support, also known as PAS, allows the provider system to send and the payer system to receive prior authorization requests using EHR while still meeting regulatory mandated X12 278 requirement, which require to transport the prior authorization, potentially simplifying processing for either or both the exchange partners. Now let's talk a little bit about the architecture. Uh, First we'll talk about the coverage requirement discovery, then we'll move into DTR, and finally we'll talk about PAS. All these three implementation guides, they work together hand in hand to define the overall data flow and to define the end-to-end architecture. So there are multiple stakeholders in this process. So we have provider, we have clinical system, we have hooks which are used to connect the various resources. We have smart app, we have payer side of things, and then finally the prior authorization processor. So as part of the coverage requirement discovery, the first step is to create the order, referral, etc. So as part of this process, the first question is there anything provider should know? So we do retrieve the patient details from the hooks. And then is there a coverage requirement? Is there any additional documentation that needs to be filled in? If there is a coverage requirement, that information will be returned back to the provider. Now we move on to the documentation, template, and rules DTR flow. So in this particular flow, the provider clicks on the smart app card. Usually it's part of the EHR system. They retrieve the documentation SQL rules which needs to be filled in. The user verifies the information that is part of this questionnaire response. And then once this information is shared with the smart app, then finally this information is stored in the system. The final piece of the puzzle is the prior authorization support. So once the provider has the coverage information, they have filled in all the required information. They have the information about the prior authorization rules or the SQL rules from the payer. The last step is the provider requests the prior authorization. The prior authorization request goes to the payer system in the X12 format. The payer system returns the X12 278 response. The information is received by the FHIR server and then displayed in the prior authorization system as a prior authorization response. Moving on, next we are going to talk about what exactly is coverage requirement discovery. So the process of managing billing for patient insurance is a significant source of complexity and cost in the United States. Healthcare providers work with a range of different health insurers and payers who cover the services the providers supply to patients, different payers and plans. They provide different level of coverage for healthcare services with different processes for determining whether services are necessary or are appropriate. Different processes have different requirement for documentation, prior authorization, or other approvals. Providers who fail to adhere to payer or coverage expectations may find that costs for a given service are not covered or are only partially covered. The outcome of this failure to conform to payer requirement can be increased out-of-pocket expenses for patient, additional visits, changes to ordered therapy, and increased costs for both patients and providers. The Coverage Requirement Discovery Implementation Guide defines a workflow to allow payers to provide information about coverage requirement to healthcare providers through their clinical systems at the time treatment decisions are being made. This will ensure that clinicians and administrative staff they have capability to make informed decisions and meet the requirements of the patient's insurance coverage. This implementation guide supports both protected health information, also known as PHI, and non-protected health information for CRD to meet the needs and privileges of different payer organizations. These mechanisms will allow payers to share a wide variety of information with providers in a context-sensitive manner, which includes updates to the coverage information, alternative preferred first-time, lower-cost services or product, documentation requirement and rules related to coverage, form and template to complete, indications of whether prior authorization is required. Now we'll talk about various CRD scenarios. The first scenario is Mrs. Jones is a 35-year-old previously healthy female who is seen by Dr. Good for a new onset headache that began abruptly 2 weeks prior to her visit. Her headaches are severe at times, last several hours, have been occurring with increasing frequency and are now occurring daily. Her physical, including neurologic exam, is normal. Dr. Good is concerned about an intracranial process. Dr. Good wants to order a head CT to check for any masses but is unsure whether the service would be covered by Mrs. Jones' payer, and if so, whether special authorization or documentation will be required. Dr. Good launches an app within his electronic medical record EMR and indicates that he wants to see coverage requirement for Mrs. Jones' plan for a head CT. The app sends a query to a CRD service used by Mrs. Jones' payer asking for any requirements corresponding to her coverage. The CRD service returns information within a few seconds, identifying that a prior authorization request must be completed and submitted as well as the additional clinical documentation required, for example, progress notes, prior studies, etc. It also provides a link to the required form. Dr. Good completes the necessary paperwork to initiate a prior authorization and sends the relevant supporting information to the imaging center as part of the referral. So this is the part where Dr. Good has submitted the prior authorization. Now he has to wait until the payer comes back with a prior authorization response in form of X12278, and then that will be converted into FHIR. Now the second scenario is Mrs. Smith is a 75-year-old female on a Medicare fee-for-service plan with long-standing chronic obstructive pulmonary disease COPD, which has had slowly and progressively worsening shortness of breath with activity. In the office, her room air saturation after a 5-minute walk is found to be 84%. She has additional evaluation that reveals no new findings. Dr. Good wants to initiate home oxygen therapy for Mrs. Smith. As Dr. Good begins crafting the order in his EMR, it uses Mrs. Smith's coverage information to initiate a querying to a CRD service used by her payer that includes the code for home oxygen therapy. An alert appears at the bottom of the EMR order entry screen notifying Dr. Good that specific testing and documentation is required to substantiate the need for the home oxygen therapy. Dr. Good retrieves specified documentation template which have already been populated with information from his EMR. He completes any remaining documentation requirement, signs the documentation, and includes it in Mrs. Smith's medical record. Again, in this scenario, the prior authorization request has been submitted and we have to wait until we receive the X12278 prior authorization response from the payer. We'll talk about the one last scenario. Mrs. Light is a 45-year-old, generally healthy male who presents for an annual exam. His physical exam is normal. Dr. Good checks a basic metabolic panel and determines that Mr. Light's kidney function is diminished. which is now compared to his function 1 year ago. Dr. Good wants to refer Mr. Light to a neurologist for further evaluation. As Dr. Good is completing the referral, his EMR contacts a CRD service used by Mr. Light's health plan. The service notifies him that the referral to the covered services under Mr. Light's coverage, the physician must require prior authorization and provide specific medication documentation as part of the request. The EMR provides a link to an insurer-provided app that displays the form, partly populated with information from his EMR, and guides him through the process of completing the information needed for the prior authorization. Overall, if we talk about CRD, there are two key stakeholders, the provider and the payer. So the first step is clinical actions potentially needed. Second step is provider performs EMR action and provider starts the CRD what if scenario. The provider checks the payer system about the CRD need. Provider starts the CRD query, and there is an optional step where payer gets additional data information sharing with the provider. The payer returns the CRD results, and there is one last optional step where provider invokes the links which are shared by the payer as part of the CRD workflow. With this, pretty much we covers the overall workflow about the CRD. Hope this was informative. If you like the video, please like and subscribe to my channel. In the coming videos, we'll talk about the DTR and the pass flow. Until then, see you next time. Have a good day.